Hello friends, today we are going to discuss about under 5 asthma. Okay, I think it's a very important topic. My talk is based on 2025 GINA guidelines. First question is, does asthma occur in children below 5 years? I think 5 seconds for you. Some people may differ in their views, but what is the real status? Actually, all these publications happened 2 decades ago. The NIH says that 50 to 80% of children who have asthma develop symptoms before their fifth birthday. And another publication says that 75% of the children with a persistent asthma started to wheeze by the age of 3 years. So, asthma occurs below 5 years, but probably in less proportion. That is what, and it is difficult to diagnose this. That is what we are going to attempt now. There are many causes that cause wheeze below 5 years, starting from viral infections, particularly the recurrent viral infections. And I have given all these things. We all know about that: dysplasia, malacia, reflux, cystic fibrosis, immunodeficiency. All these can occur below 5 years. So, can we fish? I am telling about joking, that is asthma fish in a pool of under 5 years fishes. That is what we are going to attempt. The answer we can see in the end. In the past, there are a lot of advice about under 5 years. Some are based on the cohort studies. Some advice is based upon time trend based classification. I think all they contributed their own share. I don't say nothing, but they have done their best in the time. But today, GINA has given a very new view about that. That is what we are going to discuss. And it's fairly a simple one. GINA says, any child presenting with a recurrent wheeze, you have to observe 3 things. If all the 3 clinical criteria are met with, you can name them as asthma even below 5 years. What are the clinical criteria? Number 1 is presentation, recurrent wheezing. And I am going to explain in the better way in the other slide. You cannot see in that. So what they say, how they present. Okay, the presence of recurrent acute wheezing or at least one acute episode of wheeze with asthma-like symptoms. This is very, very important. I think we can have a better view about this in the next slide. So the presentation is very important, I said. Second, how they respond to treatment. I said about the presentation, that is either a recurrent means more than 2 attacks or at least 1 attack with asthma-like symptoms in between. Then how they respond to your treatment. See, if the child comes with acute wheeze, you are giving SABA, there is a marked response within 5 minutes or something like that. That is very typically go with the asthma. Or even if the child has a severe episode, in a hospital they are giving SABA as well as oral corticosteroids, and the child gets within 3 to 4 hours, then that is also asthma. Okay, and that such things can happen only in asthma. That is what we mean. Sometimes the child may have a less severe episodes. You go for a therapeutic trial we are going to discuss. And it is understood that before making a diagnosis of asthma in below 5 years, we have to rule out alternative causes of wheeze. That's what we are going to see. All the 3 criteria should meet to call it as asthma. And if only 1 or 2 criteria are met, then you can call it as a suspected asthma. Okay, that is also clearly given. But what sometimes this suspected asthma sometimes may give unhappiness because of the social stigma and all. See, it is a suspected only. You can use as a suspected asthma or even in a multi-trigger wheeze. That is my view, I am telling. Then what is acute wheeze? Acute wheezing episode means child presenting with wheezing, breathlessness, with accessory muscle acting, at least, or even just the episode should be more or last for about 24 hours. That is very important. Then I have told about asthma-like symptoms. Sometimes it is also called interval symptoms. What is that? Here the child asthma-like symptoms means the child may present with a cough, wheezing, particularly after running, laughing, crying, or during sleep. That is asthma-like symptoms. Okay, and if the child has family history of allergy or personal history of dermatitis or allergic rhinitis, then it is strengthened to diagnosis. GINA is very clear. Sometimes before you are given very importance, that's a very good, it's good, but you cannot solely make a diagnosis. Is one of the factors that go with the majority of the children. That's what asthma say. Then coming to therapeutic trial, I said any child presenting with the mild symptoms that doesn't warrant any treatment for acute wheeze. Sometimes they simply go with the one nebulization, two nebulization, like that they go for a long time, and there is a strong clinical suspicion of asthma. Then put the child on therapeutic trial with inhaled budesonide, 100 mics twice daily, and in between you can use SABA as a reliever, ideally MDI. This can be given as a space with mask, and you give for at least 2 months. And if the mother comes and says my child is totally all right now, then child responded to the inflammation settled down. That's why child is responding to the treatment. And if you stop, the child start recurring the symptoms. And if such things happen, you make a diagnosis of asthma. From that time onwards, you can treat the child as a asthma in under 5 children. I already said there are many alternative causes that produce wheezing in children below 5 years. The neck-to-neck comparison is between the recurrent viral infections and asthma. Actually, what they say, some of the viruses are notably produce severe wheeze. Okay, that we are going to discuss. Then, child, sometimes not necessarily GI or RD, gastroesophageal reflex, child may produce vomit, and that may produce a cough, sometimes mild wheeze. You have to always rule out this. Tracheomalacia. Among the malatias, I feel tracheomalacia is very, very common, and I have demonstrated many child presenting with a recurrent admission in the hospital below 1 year, and these children are not responding to the treatment for asthma treatment. They typically present with harsh cough, noisy breathing, especially after crying, and if it is happening since birth, you have to strongly suspect tracheomalacia. Then bronchopulmonary dysplasia. I think everybody knows that a newborn or a premature infant, particularly low birth weight requiring prolonged oxygen or ventilator support, presenting with a wheeze. Protracted bacterial bronchitis. I think recently I come across many of the children are treated as asthma, because here the demonstration of wet cough is very, very important. You cannot rely upon the mothers. You ask the patient to wait in your clinic room and ask him and listen how they cough. And if you convince about the wet cough, then you make a clinical diagnosis of. And that too, if it is lasts for more than 4 weeks, already the child would have seen several doctors not improving, but there is no background history of past history of wheeze. You can make the diagnosis of protracted bacterial bronchitis. Pertussis, I think still there in some parts of the world. You have to be careful about that. Child typically present with the inspiratory group. And tuberculosis, I always say, though cough and fever is the manifestation, fever is very, very important. And the contact in the family is also very important. And any child presenting with more than 2 weeks of fever with cough, then you make a diagnosis. Then upper airway cough syndrome, it is due to the draining or dripping of the mucus in the throat, causing these child will have the nasal symptoms all. You have to examine the child. That is also very important. When you happen to encounter failure to thrive, the reason name is growth faltering. You have to be very careful, look for clubbing, because all these things shows that underlying chronic conditions like bronchiectasis, CF, and I already said some of these points. Multifocal infection means you have to rule out immunodeficiency. GINA says that the younger the child, the higher the likelihood of viral infections. It is not asthma. So if you are making a diagnosis at 1 year, I think you are invariably wrong. Why I am telling is, in younger age group, the viral infections plays a very, very important role. For example, 100 children come for a wheeze, majority are viral infection. That is why recurrent viral infections. I already told about the alternative causes, and a typical clinical examination is very important. After ruling out only, you have to consider asthma. That's what we have been discussing. Coming to the respiratory viruses, I think all the viruses have the potential to produce cough and wheeze, but particularly the rhinovirus and RSV plays a major role to produce wheeze. Actually, if the child is having underlying atopy, these viruses interact with the atopic status and produce or unmask the manifestation of wheezing tendency. All these respiratory viruses are given here have the potential to produce cough and wheeze. That is the reason, see what WHO says, a particular child may get 6 to 8 attacks of URI, viral URI. Okay, so all these things, if happen successfully, they will typically present as a asthma. So you have to rule out. That's the reason why I am repeatedly telling, think about the viral infections in the younger age group. I think this I purposely showed because I have done a lot of bronchoscope. Many child referred to me, child is already 3 to 4 times admitted in many nursing home. They given asthma treatment, but child is not improving. What is happening? Look at the normal trachea, and this is a normal trachea. Okay, can you see that? This is a normal trachea. This is a tracheomalacia. Here the cartilage is defect. So the contour is maintained by the muscle, smooth muscle tone. So if you give beta agonist, actually it worsen because the muscle become more compliant, more collapsible, and the child may not improve with your beta agonist. In fact, mother says that, some of the mothers say, typical, sir, I am not getting improvement with that treatment, and that is the reason why postural drainage or chest physiotherapy along with hypnotropium bromide helps a lot in these children. I think this is also, it is not very pertaining. I just want to show some of the pictures. We are living in India. In India, still tuberculosis is going on, and even sometimes I have come across this very, very rare, very, very rare. I am telling you, tuberculosis may present. They may produce allergy and also producing a wheeze. That you have to keep in your back of your mind. Look at how the caesium look like that. That is why I am showing this picture. And in the evaluation of under 5 weeks, don't forget about the allergic rhinosinusitis. Okay, what they say, 70 to 80% of children with asthma, they have allergic rhinosinusitis. This is very important. And sometimes it may happen without asthma also. You should know how to differentiate between these two. And most of the times they may go together also, you have to know that. And in younger age group below 5 years and all, adenoidal hypertrophy is a problem. They may typically present with air infections, blocked nose, mouth breathing, and so on. So when you started, I think this should be coming to next slide, but I am still there. In younger age group, particularly below 3 years or sometime with if they are not able to understand even below 4 years, you can use NDA with the spacer with the mask. But if the child age is more than 4 years, then you can go for spacer. Spacer is a versatile instrument because it gives a lot of benefits. It eliminates the hand-lung coordination, and it also reduces the oral candidiasis, vocal cord myopathy, and so on. A word about how to treat mild exacerbation and all. I think this is already given in the book. Probably any child develop in the home. You can always give parents, they can use SABA every 20 minutes. That is albuterol or salbutamol. Every puff releases 100 mics. You can go up to 4 puffs every 20 minutes. And some people want to use nebulization. You go for 2.5 milligram of nebulization every 20 minutes. Most of the symptoms may get settled with that. And okay, that is a very important one. And now moderate to severe wheezing and all, you have to go for addition of ipratropium. Ipratropium is a very important one because it acts in a different way. Actually, salbutamol acts by increasing the cyclic AMP, whereas ipratropium, it inhibits muscarinic action, thereby it reduces the cyclic GMP. And these are all only I have given for your reference. Now we will go to the, see, you have made a diagnosis of children, that is a child comes below 5 years, your clinical presentation, your response to treatment, and your route is very, very good, has been given in the GINA, and we already rule out some of the alternative causes. Then you can label the child as an asthma below 5 years. So from that time onwards, you have to follow you have to follow the asthma protocol. Actually, GINA approaches asthma in 3 age group: below 5 years, 6 years to 11 years, and 12 years, and 17 years. That is adolescent, then adults, like that. So here you made a diagnosis of asthma, and it is a step. There are 4 steps are given. First step, you can go treat the attacks both with salbutamol as well as inhaled budesonide on demand basis, SOS basis. Step 1, you can manage like that for some time, but most of the children may not fit in. They simply, I usually start with the step 2, low dose inhaled corticosteroids. On top of that, if the child develops any acute symptoms, we'll use a reliever. That's a very important one. If the child is still not responding, go for step 3, where you are actually doubling the dose of ICS. These all the, I think this is a one that is classically given. You can go there. You can ask me why early diagnosis of asthma is very important. See, even though parental point of view is very concerned, asthma is a lifetime disease. Once asthma, you made a diagnosis, it is very difficult to change the natural course. Okay, and unless there are some biologics are coming to the market, but still you have to be very careful. That's the reason why if you strongly suspect asthma, you have to make a diagnosis and start a proper treatment. Otherwise, the child will be unnecessarily exposed to oral corticosteroids or even antibiotics and all. And if the child is missed the diagnosis, go for silent remodeling. Actually, the subepithelial fibrosis and all happen. That should not. That is the reason why I am talking about that. And recently, GINA also gives some warning about one size fits all. Don't go with that attitude. Even though, by and large, asthma is a type 2 disease. Still, some reports say that some of them are fitting into the other category, that is neutrophilic type. Okay, you should be very careful. How to know? Go look for biomarkers, type 2 asthma biomarkers, particularly FeNO, blood eosinophils. But blood eosinophils and all in a developing country is very difficult, because of the parasitic infection. Go for either estimation of total IgE or allergen specific IgE. All these things may say that the child is having, if it is all elevated, or then it is towards a type 2 inflammation is going on. A word about lung oximetry, because I always fascinated about that. It's a very beautiful technique. Spirometry you have to do in a older child around 5 to 6 years. It needs a lot of efforts. Child should cooperate with us, but it can be this oscillometry FOT simply can done in it with a smaller child, even 3-year-old old, and tidal breathing is enough, and it sends two important waves, namely the monofrequency waves of 5 Hz and 20 Hz, and everything is nicely calculated, and this is a very useful technique. We will discuss separately later, and I think whatever may be, there is a reference values may not be there, but you can have a compare after bronchodilation. That gives a lot of thing. See why it is not been included. GINA encourages to do oscillometry, but still it's not included as a this one. But wherever possible you can do that, and most of the times you can demonstrate BDR, bronchodilator reversibility. So before and after dilator, it's a marked improvement. Bronchodilator change is 40 to 50% in R5 and AX. Then it shows the underlying problem, asthma. So now I am coming to the last questions. You all agree with me. First I can say that, can we fish asthma fish in a pool of under 5 cases? Now you all agree with me. You can fish by ruling out the other causes that has been given here, and you watch for the clinical presentation, and that is acute V's, how they respond to your albuterol or salbutamol, and if there is not a therapeutic trial, if all the three are happening, says that then if all the three are there and you are already ruling out alternative causes of V's, then you can firmly make a diagnosis of asthma even below 5 years. I think this might be the last slide. Thank you very much. Thank you very much for listening and all. And any questions and all,